procedures am I currently using the diode for? I'd say your bread and butter procedures are your gingivectomy for bracket placement and access to placing brackets accurately. To me, that is the #1 advantage, day in, day out advantage of the laser. We do not compromise bracket placement in our practice. This is where we gain great efficiency by looking at a case ahead of time. For instance, in my exams, we have a probe and we check for passive eruption, tissue that's being brought down by erupting bicuspids, and we all know those second bicuspids are sort of the bane of orthodontics. We're trying to get the braces on, the teeth are just coming in. So this is an opportunity to get all the brackets on at once and have good access for it. So gingivectomy for bracket placement is a big one. Perculectomies are routine, canine exposures, routine stuff. Maxillary frenectomies at the end of treatment for us are sort of the bread and butter. If you're talking about advanced procedures, the most fun procedure we do is a cosmetic recontouring. So if you take the upper anterior 6 teeth at the end of braces for somebody who has a lot of hyperplasia, they'll be really proud of their smile, as you'll see in the later videos. A video for hygiene. This particular case actually has pretty clean teeth, but you'll notice for patients that aren't in the habit of flossing, they'll get the papilla that pop up from time to time, and they have a question about, what do I do about this? What I'm doing actually is an internal beveled incision to simply lop off the top of that papilla. And if you had to describe it specifically, I'm coming from the base of the papilla. If you imagine the papilla like a triangle, it came from the base first, and I aimed at sort of the contact point. So all I'm doing is cleaving off the top of the papilla. Now I'm just shaping up the sides of that so that it's good. Okay, that's a good picture to just look at as we finish up this video. Now that's a neat thing to do for a patient, and it's simple, keeps everything clean, and they're proud of their smile, and their parents like that when you help them out in such a way. This is a neat procedure coming up, and it requires that I give you a little history on this patient. The patient had a powerfully impacted maxillary left canine, and you're looking at the upper occlusal view, I guess that's my operator's view. And in this case, the patient had an infection following the exposure, and we weren't able to begin doing the treatment. And so the chain, it basically healed up at the crest of the ridge, because as the surgeon just tied that chain to the lateral incisor. Well, the canine's down in the palate. This is one of the deeper, more horizontal impactions you'll see from time to time. And so rather than send the patient back for another procedure where they already had a problem one time, I can use a laser that sterilizes as it cuts, and I can literally be putting a light tension on the chain. This is a gold chain attached to the permanent canine, and we were able to document this really nicely with the 3D views that we're getting on the cone beam CT and know exactly where we were going. But you see how many links of chain would it take to have just drug that chain through the tissue. It would have been months of treatment just to get the chain taut, because I needed to pull this canine away from the roots, or lingual to the roots of those incisors as a first step, and then to extrude the tooth first, and then do it labially. Had I just pulled from where the chain came out, the risk of resorbing the roots of those anterior teeth. So with the 3D views, I was able to determine the strategy, and then with the laser, I was able to execute the plan without any help. So that turned out to be just a win-win for us and the patient, and a neat advanced use of the laser. A lot of people are interested in what the patients think about the laser and what's the post-op reaction for the patient. It's a little scary for a patient to hear about lasers. So we include the informed consent in all of our consent forms, and so that when we do have to approach a patient about laser, we're not getting paperwork out and having to get things signed ahead at that time. We did it ahead of time, and we take time to explain it at that time. But the patients are a little nervous at first when we show them some cases and things like that. It's good to have some pictures or some videos or anything you might show them. But the kids think it's pretty neat. And then when you tell them you're not going to have to give them a shot to do that, it's even better. So we talk about using topical anesthetic, and of course the post-op is a no-brainer. There's really very little risk. We've never had a case of infection. We've never had any real post-op pain. We've had patients that literally go eat Mexican after the procedure. They told us they went out to eat Mexican food or salsa after the procedure. So indirectly, I guess you create a Band-Aid during the course of the treatment, and the laser, as I mentioned, sterilizes as it cuts. So post-op experience is a wow. It's a fantastic procedure to be involved with because there's very little, problems post-op. We're moving on to one of the more common things we do. We've got anesthesia with the topical anesthetic here, and we're checking that with a cotton plier as we begin our maxillary labial frenectomy. Now, the starting point for labial frenectomy is not at the tip of the papilla. It's at the insertion of the frenum. So you can notice I'm sparing the papilla in the midline because we don't want to generate any heat there. We don't want to have any crestal bone loss from any heat. So it's a surface procedure, and we're working right along the long axis of the alveolar ridge, and we're just working back and forth. I'm keeping some light tension on the upper lip, and as we work our way down through the epithelium, you'll see that characteristic diamond-shaped pattern coming up that's typical for most frenectomies. Our goal in this procedure is to detach the connective tissue fibrils that dive through the frenum that support that epithelium. And in